Hi, this is Dr. Gollum, and today we're going over Module 1, Payment Basics, Section 3, Referrals and Primary Care Partnership. The two previous lectures have been on Sections 1 and 2, and this time we are focusing again on referrals and primary care partnership. Here's a preview as to what we're going to go over in this section. We're going to talk about referrals and primary care partnership resources. So these are the resources that we would provide the primary care providers or primary care physicians as dietitians. The main resource that we're going to go through section by section is the toolkit, which you'll find all of these resources in your Canvas course materials. But we're going to go over each section of this toolkit, and it's a toolkit, again, made for PCPs by dietitians. Before we move on from this slide, I do want to mention that I put a link here to a webinar that's very helpful and useful. It is free to Academy members, and you should watch it. Go ahead and download and take out the toolkit, Referrals to a Registered Dietitian Nutritionist, that's made for primary care providers, and look at the table of contents. Now, we will be going over every one of these sections. I'll be summarizing them so that you can not only know this information, but be able to reference it in the future. So we will go over the value of RDN services to PCPs, clinical and practice guidelines, reasons for underutilization of RDNs and lack of RDN referrals, current coverage for nutrition services, and you can see there's reference to Medicare, Medicaid, and private insurance plans, which we have covered briefly in the beginning of this module. Then we'll move on to effective referral messaging, referral tools, filling the gap, coding for nutrition services, and then a business model or business models for RDN and PCP partnerships. The main purpose of this toolkit is to provide a collective resource for PCPs. So you'll find all the information, examples, and tools needed to successfully partner with dietitians to provide care to patients. This toolkit really helps to support that team-based care. Now, when using this, PCPs can skip to any section that they need at any given time. So it's really a good reference tool for them. So it is important to note that our healthcare in the past couple of decades has really been pushing towards this comprehensive format where a team is involved. However, even with that, less than 45% of primary care visits with nutrition-related conditions include nutrition counseling. And so that means, not even half of all those who could be receiving nutrition counseling from a primary care setting are. And that is often because acute concerns about health often outweigh those chronic care management when the physician has a very short amount of time with the patient during their short appointments. Also, the majority of primary care physicians lack the time or the nutrition expertise to offer nutrition counseling themselves. So there's a great value in including the RDN on the team. In fact, studies have revealed that for every dollar spent in an RDN-led lifestyle modification program, there is about $15 in return. That's $15 in savings in other healthcare. And so that's a pretty good ratio there. Now, the MNT provided by RDNs has also been studied and revealed to show that it improves clinical outcomes, it reduces costs related to the primary care physician's time, and decreases medication usage, and reduces hospital admissions. So this is just some of the many benefits of including an RDN on the PCP team. You'll notice that a lot of the resources out there and this toolkit focus mainly on the RDN's role in the treatment and management of obesity and diabetes. However, there are a lot of other conditions that RDNs can assist with, and that includes hypertension, disorders of lipid metabolism, heart failure, gastrointestinal disorders, GERD, chronic kidney disease, gestational conditions, pediatric growth issues, and also the diabetes that's not related to obesity. So it's important that PCPs understand that there's a variety of conditions that are nutritionally related and that the RDN can help with. This is where you can refer to the RDN and PCP's A Healthy Partnership for Primary Care handout and read about the benefits of adding an RDN to the team. And this is a handout that you would provide, or any advocate would provide, to a primary care facility or physician. And there's also the RDN stakeholder flyer, which is much easier kind of picture to look at to get the message across of the benefits and value of adding a dietitian to the team. Here's some review, but worth mentioning. The clinical and practice guidelines. Lifestyle modification is highly effective. It's evidence-based interventions, and nutrition is a major modifiable lifestyle risk factor. This is something that needs to be repeated to physicians in the field. Now, it has been recommended by many associations and organizations and experts that chronic disease management and lifestyle guidelines should include medical nutrition therapy that's provided by dietitians, registered dietitians. Now, just so that you are all on the same page, RDs, registered dietitians, and RDNs, registered dietitian nutritionists, are the exact same credentialed expert. The name changed in the previous decade, and really it's up to the practitioner as to which credential title they want to choose, the RD or RDN. So it's very individual, but it's the exact same credential. Anyway, moving on. So there are lifestyle management medical care guidelines that are included in this toolkit and that are discussed to a bit. For example, diabetes and diabetes self-management education. 3 to 6 MNT visits are covered with an RDN during the first 6 months, and greater than 1 follow-up visit is also covered. Now, more are covered as needed, and they've been shown to lower the hemoglobin A1C values and improve quality of life of patients. And that these improvements are maintained with continued MNT visits. Now, in pediatrics, MNT is essential to facilitating accurate dosing of insulin, and this is often new information to physicians. They don't recognize that dietitians are versed on insulin dosing and balancing insulin with food intake and preventing hypoglycemia. They believe that perhaps only they know about the food and nutrient intake side, but we're educated on both the balance of insulin and food intake. And so that's extremely helpful information to them. And to know that we're also covered is good information for them to say, maybe I should refer to a registered dietitian nutritionist. The U.S. Preventative Services Task Force, the American Heart Association, the American College of Cardiology, and the Obesity Society all agree that intensive nutrition counseling provided by clinicians, mostly RDNs, should be recommended for adults with overweight or obesity who also have chronic conditions. Now, at least 14 MNT visits over a minimum of 6 months are needed for weight loss, and they recommend that a minimum of monthly MNT visits are needed for at least a year to maintain that weight loss. They also recommend that clinicians screen for obesity in children and adolescents that are 6 years and older and offer them the comprehensive intensive behavioral interventions provided by a dietitian to promote improvements in their weight status. Now, the American Academy of Pediatrics provides recommendations for assessment and management of childhood obesity in patients that are aged 2 years or older. And there's an assessment and treatment algorithm on the American Academy of Pediatrics Institute for Healthy Childhood Weight website, and I left the link on this slide. This is a great resource for PCPs, and it's good information for them to understand that a lot of our leading organizations are providing guidelines for the use of dietitians in their practice. The next section talks about the reasons for underutilization of RDNs and lack of RDN referrals. We all know that nutrition plays a significant role in the prevention and management of the leading causes of death and chronic disease in the U.S. However, this really isn't sufficiently emphasized in clinical settings, and PCPs do not commonly refer their patients to the services of an RDN. And so the question is, why? Why not? Why aren't they doing this? And some of the answers are there's a lack of PCP training and full understanding of the role of nutrition in health. There's limited understanding of the role and expertise of the RDN. There is a lack of referral networks. There's also continued use of the fee-for-service model, and we'll get into what that is and how that contributes to this underutilization later. There's a misunderstanding of reimbursement and patient coverage. And there's this underutilization of these team-based care and care coordination models. So let's talk about each one of these. But before we move on, let me emphasize the lack of PCP training and full understanding of the role of nutrition in health. Now, on average, PCPs only receive 21 hours of nutrition training during their medical education. And this is well accepted, even with physicians, that amount of time is completely inadequate for them to be able to respond to most patient questions and concerns about diet and lifestyle change. PCPs are not trained in competencies related to lifestyle or behavior modification as a frontline therapy to treat or prevent chronic disease. Instead, medical training typically focuses on pharmaceutical intervention management. And so that's typically what they lean to. They go towards their training and what they know. Until recently, the U.S. healthcare system has focused on episodic care, which means treating and managing disease episodes, so when they're diagnosed and on, instead of treating the whole person. PCPs were able to bill for each service that they provided to a patient, that fee for service, which this model unintentionally rewards the continued management of illness as opposed to management of wellness, because they get paid more with the more medical services that are provided. What helped with this was the passage of MACRA. It helped us move our system away from the fee-for-service model. MACRA stands for Medicare Access and CHIP Reauthorization Act of 2015. And again, like I said, this moves our system away from that fee-for-service model and toward a value-based payment. So it emphasizes quality and coordinated patient care, coordinated with other healthcare providers. And PCPs are paid more when their patient population maintains good health. So instead of being paid more when you provide more medical services and your patients may not be doing that great, they're paid more when their patient population is doing better and becomes healthier. But even though this is occurring and available, a majority of PCPs still utilize the fee-for-service model, and this really limits the incentive to refer a patient to an RDN. There's also a lot of major confusion surrounding reimbursement for RDN services with the fee-for-service model. Medicare covers RDN services and care, but not all RDNs are Medicare providers, so that can be confusing. Medicaid coverage differs state to state, so that can add to the confusion. And commercial payers, like commercial insurance companies and organizations, their coverage of nutrition benefits differs from plan to plan. So add a little more confusion to the mix. Here's some more reasons as to why RDNs are underutilized and there's lack of referrals. Team-based care or coordination is still not really emphasized as an optimal practice design outside of that inpatient setting. So we are seeing inpatient setting, they're doing really well, but when you get to outpatient and primary care facilities and offices, this team-based care hasn't really caught on. Part of the reason is we need to have more evidence that it's needed in these settings to reveal the significant benefits of integrating an RDN in primary care settings. Business models and practice examples of how to incorporate an RDN into healthcare services are also needed to promote more referrals and use of dietitians. And in the end, PCPs really need to know how to contract with or employ RDNs. They need to know how to align practice flow with the inclusion of an RDN. So when a patient comes in, who are they all going to see? And how would that look like in terms of the flow within their practice? And they also need to revise their case management protocols. So how do you revise your case management protocols to include an RDN as part of your team? Quickly, I want you to recognize that the slide previously was talking about the reasons why RDNs are underutilized and there's lack of referral. And I want to make sure that you understand that this toolkit is actually going to have an answer to each one of those problems, and it'll address each one. Now, I included this slide because I want you to specifically recognize what a patient-centered medical home is referring to and what accountable care organizations are referring to. And we will mention these a few times within the course, but let's just make sure we're all on the same page. So, the patient-centered medical home is a philosophy of primary care that is focused on the individual. Okay, so it's bringing comprehensive team-based coordinated, accessible care to individuals. The medical home is really talking about the primary care physician and the primary care office. And a medical neighborhood is referring to all the healthcare services for patients that are auxiliary. So this includes RDN provided nutrition services, it includes community and social services, and state and local public health services. These are all added in that medical neighborhood, where the medical home is really the primary service for healthcare. And in this philosophy, the medical home and the medical neighborhood are equally important. And they're looking at individuals as a whole, not just treating their diagnoses. Okay, so the next concept is the accountable care organization. And this is designated organizations of providers that are jointly held accountable for achieving measured quality improvements and reductions in the rate of spending for a defined population of patients. And so there's many of them out there, and they can include a variety of different providers, which includes primary care practices and specialists, including dietitians. And basically, they come together and recognize we are an ACO, and we are accountable for making sure that there's these health improvements and this efficient rate of spending. Now, you can learn more about both of these concepts in the article by Jortberg that I provided you in the course materials. It's called RDNs Bring Value to Emerging Healthcare Delivery Models. And they go into these two in depth. Now, the underutilization and lack of referrals to RDNs also extends beyond just the primary care physician, because even when a referral to an RDN is made, the patient has to understand the value of the RDN's expertise. And that means if they do that, if the patient really values and understands the value of an RDN, they'll follow through with scheduling their appointments, attending their appointments, and really engaging in the visits and the work. We have to also consider that when a referral is made to RDN, it's very important that the communication between an RDN and a PCP is consistent and cyclical. Okay. So the toolkit addresses, again, many of these issues and offers tools and tips to PCPs so that they can overcome some of these obstacles. Moving on to the next section of the toolkit, which is current coverage for nutrition services. There's a big myth out there. Many medical providers are under this assumption that's incorrect, that payment for nutrition services does not exist. And that's a complete myth. The truth is, benefits for nutrition counseling have evolved, and coverage includes everything from face-to-face as well as telehealth visits with an RDN. There is coverage with Medicare, coverage with Medicaid, there's coverage from private insurance plans. We've talked about a lot of these before. There's coverage from My Healthy Weight program, and then there's even out-of-pocket coverage that some patients are more than willing to pay for this out of pocket. I mean, let's think about it. We're talking multi-billion-dollar industry when it comes to weight loss. So there's a lot of out-of-pocket money that's already being spent. How nice would it be if it went to professionals who really knew what they were doing and who had medical supervision? The toolkit goes on to discuss each of these types of coverage, and we've discussed this a little before in the previous sections of Module 1, but we can go over this really briefly here. There is Medicare coverage, MNT, for diabetes, for non-dialysis kidney disease, and 36 months post-kidney transplant. It's covered. 3 hours of MNT in the initial year of referral, 2 hours of MNT for subsequent years. I mean, this is nothing that you have to memorize. And the truth is, we're hoping this changes and increases. But you do need to know that you have to refer to these different areas to make sure what is the coverage, who is covered. Now, there's additional coverage with Medicare with a second referral in the same year for a change in diagnosis, a change in medical condition, or a change in treatment regimen. And the reason I put stars next to this one is that it's often missed. If PCPs don't know that there's additional coverage for more nutrition services when they do change any of those aspects, they're not going to refer. But it's covered. There's money there for extra service, and so it needs to be taken advantage of. Also, there are some Medicare Advantage Plus plans that offer nutrition service benefits, and that should be investigated. There's also coverage for Medicare participants in Medicare Part B for intensive behavioral therapy for obesity. So that could include dietitian services as an incident to physician services, and we'll talk about incident to later. There's coverage for Medicare Diabetes Prevention Program. There's coverage for diabetes self-management training. And there's a lot of other innovation models, and innovation model participants may have access to a lot of RDN services, and you can see the link for more details. Now, CMS means Centers for Medicare and Medicaid Services. This is complete review, and of course you can go and look at your materials, your course materials, for more information, but there is coverage through Medicaid. And of course this varies state to state, but there are M&T services that are covered for both adults and children. There are nutrition services that are covered in the Children's Health Insurance Program, in the National Diabetes Prevention Program, and in the Early and Periodic Screening, Diagnostic, and Treatment plans and program. So PCPs need to be made aware of this as well, and it's included in the toolkit. Coverage for nutrition services from private insurance companies really depends on the plan and policy, like we discussed before. But we also mentioned that due to the Affordable Care Act, many private insurance companies are including nutrition services in their benefits. And the coverage really varies. But it's important to go investigate, because the coverage, it could be covered under preventive benefits, incident to physician services, PMPM, which is per member per month, and I put a little link there if you want to look this up. It's a little too in-depth for this course, but you're more than welcome to learn more. And then also it could be covered under bundled payments. And these again are aspects that PCPs need to know. The next section of the toolkit is titled Effective Referral Messaging, and we know that the PCP influences the likelihood of a patient successfully meeting with an RDN to receive MNT. And so the way that they bring this up to the patient, and the way they present everything and obtain information from the patient, will really help move forward in this process. So we want to make sure that we improve their communication about MNT to patients. And so how would we do this? Well, they need to increase their knowledge and their familiarity with the ongoings of a typical RDN visit so that they can prime the patients. They want to use people first language. We encourage this for all practitioners, but it's very important so that they recognize that they're going to be going into a setting that uses this. People first language is basically using terms like weight and BMI instead of obese, fat, or weight problem, and literally putting the person first. This is a person with a condition, not a conditioned person. So a child with unhealthy weight instead of saying an obese child, or saying an adult with diabetes instead of saying a diabetic adult. Now, we learned a lot about this in nutrition communication and nutrition counseling, but that does not mean that PCPs learn this. They also have to have a conversation about weight, chronic disease, and nutrition. It really starts with bringing up the conversation. If a PCP does not bring up this conversation with the patient who needs it, then there will be no second step of referring to a dietitian. So having that conversation may be hard, but needs to happen. So it starts with an empathetic statement, then the MD asks for permission, and there's a lot of other tips and examples provided in this toolkit as to how that conversation can proceed. They say one of the tips is to keep it positive, basically having confidence in the process, in the person, in the expert, in the experience, and explain what the patient might expect from the nutrition counseling process, to provide support if the patient tries to reach out for more help, and really emphasize that a referral is not to address a failure, but rather to increase the likelihood of success with this next step. And then PCPs in this toolkit are advised to consider a warm handoff. Now, warm handoff really means a handoff that occurs in front of the patient. So there's transparency. Basically, it would literally mean that the physician would hold a conversation, referral form, whatnot, in front of the patient so that the patient and their families are aware of the communication and have a greater sense that there's a teamwork behind this care. You can look at figure 5.1 for this 15-minute obesity prevention protocol that is provided to PCPs as an example of some sample language and steps to assess this issue and bring up the conversation. The toolkit goes on to talk about different referral tools, and that dietitians out in private practice or in outpatient settings may have a standard referral form. There's also the use of electronic MNT referrals that can save time if you're using electronic health records. But when giving a referral, it really doesn't matter what form as long as the needed information is provided. So the minimum information that a PCP is guided to provide here is their name, their signature, their contact info, and their NPI, as you remember from previous lecture. The patient's name, address, and contact info, and that may include guardian information as well as needed. The reason for referral, and they may include the codes needed that they see that are associated. And we'll go over what ICD-10 codes are later. And then their goals for the RDN treatment. What do they want to see? What are the outcomes that they want to see? There's also some helpful information, especially if the RDN doesn't have a great access to the electronic medical record. The PCP could provide this extra information, such as if the patient has any special needs, any recent lab data or current medication list, the height and weight history, or any growth charts if it's a pediatric patient, any current feeding and nutrition support regimen, if that's applicable, recent medical history and physical with their notes, including all the medical diagnoses, a copy of the patient insurance cards front and back, and that way the RDN can get a head start on looking up to see what nutrition services are covered. You can look at figures 6.1 and 6.2. They're sample forms that are provided in this toolkit. So a couple things before we move on from this. The PCP should keep the RDN referral in the patient medical record and document in their notes the need for MNT. And something for RDNs to keep in mind is that sometimes only a PCP can refer a patient to an RDN for MNT. But there are ways that a PA or NP or assisting physician could recommend or refer a patient to a dietitian, but it would be through programs like diabetes self-management training. Okay. The next section is titled Filling the Gap. And you're thinking, well, what gap? And it really is referring to the gap of nutrition education between the PCP referral and the first RDN appointment. Because this is a perfect time to address lifestyle behaviors that impact weight and diabetes. It can get the patient to start thinking about them, start looking at them, and evaluating these behaviors in their lifestyle. So the PCP really needs to bridge that gap and communicate the desired healthy lifestyle changes they want to see and identify key nutrition support educational materials and resources. And so this section provides a wealth of resources. Like they give you a sample nutrition goals contract, a wellness tips handout. There's a list of free downloadable resources, a list of patient education nutrition brochures and handouts and all the links, a list of free resources available from PCP associations, and a sample readiness to change ruler with instructions. These are great tools for dietitians to have in their back pocket as well, but these are tools that you would share with a PCP. So go ahead and reference these. You may enjoy or have seen some of these in your nutrition counseling courses. The next section of the toolkit is coding for nutrition services, and it serves to be a great introduction and a little exposure to you as students about coding before we really dive into it later in the class. Coding for nutrition services is really a key component to receiving reimbursement from third-party payers. So it's really vital when incorporating RDNs into the PCP practice. So this is different. You wouldn't need to know codes as much when you make referrals to RDNs, but PCPs, they need to know about coding when RDN is some way affiliated with their practice as an employee or a contractor or whatnot. There are three main types of codes that we'll go over. First, the MNT, Current Procedural Terminology, CPT codes. These are used by many third-party payers, including Medicare, and they describe the MNT services that RDNs provide to patients. And you can find them on the 43rd page of the toolkit. There's a list of the codes and the description of how it fits within the RDN's scope of practice. There are Healthcare Common Practice Coding System G codes, and G codes are used when additional hours of MNT services are performed beyond the number of hours that are covered. They're typically used when the PCP determines there's a change in diagnosis or medical condition and they need additional nutrition services. There's also S codes, and these were developed before CPT codes existed, and they're used in a temporary fashion for non-Medicare payers, and they're used when no other codes are really available to describe that billing situation. So again, you can refer to tables 8.1 through 8.3 to see a list of these codes that are specific to nutrition services. There's a subsection that I wanted to draw attention to. It's determining if PCP or RDN can bill for RDN services, and they specifically refer to Incident 2 physician services. Now, in order to bill Incident 2 physician services, they must meet the certain criteria. They must be an integral, although incidental, part of the physician's professional service. They must be commonly rendered without charge or included in the physician's bill, and that's typically what happens is they're included in that bill. They must be commonly furnished in the physician's offices or clinics and furnished by the physician or by auxiliary personnel under the physician's supervision. So really what this is stating in terms of RDN billing is that the RDN would have to be part of that primary care facility and under the primary care physician's supervision in order for the bill to be Incident 2. Here are two concepts or two programs that you should definitely have some exposure to. The Quality Payment Program, QPP, and Healthcare Effectiveness Data and Information Set, HEDIS. Now, HEDIS is a tool used to measure performance on important dimensions of care and service, and it's used by 90% of America's health plans. And it is helpful because it allows us to compare performance of health plans to other health plans. It's Medicare has the Quality Payment Program, and they're basically evaluating whether or not quality health care is provided at reasonable costs and payments. So what PCPs need to know and why this is in the toolkit is that RDNs are eligible to participate in the QPP and to collect data for the HEDIS, specifically childhood obesity measures. So RDNs can really help in this kind of data collection and evaluation state of healthcare within the primary care facility. So it's another benefit of having dietitians within the primary care team. The second to last section of the toolkit is where to find an RD or an RDN. And there are a lot of opportunities for PCPs to look for a dietitian. Provider networks are one, any diabetes self-management programs, hospital electronic medical records would have records of nutrition services and who provided them. There are dietitians in private practice, in the community, and in ambulatory hospital nutrition centers. The hospital outpatient nutrition offices are a great place to look. Health insurance plans of the patient may even have a registry of dietitians within their network. And then, of course, there's the online search. Now, I have here listed the Academy's registry, Find an Expert, and that helps to narrow down the field a lot more because it looks at specialty and expertise. Another unnamed place you could find dietitians is if the state requires a license, then there is a registry of licensed dietitians. However, these lists or registries rarely include the specialty of the dietitian and where they're working. It's typically just here's the name, and yes, they're currently licensed, and contact info. So I would go to the eatright.org first if all of the local resources that are listed above were exhausted and you were still in need of a dietitian. The last section of the toolkit includes business models for RDN PCP partnerships. And the RDN could work in this multidisciplinary medical practice in many different ways. They could be employed part-time, they could be employed full-time, they could be considered an independent contractor that works with the practice, they could be a consultant, or they could just work through referrals from the practice. Now, Table 10.1 within the toolkit presents this business model matrix, and it really has the basic considerations when selecting a business: the office space, who bills, the billing methods, compensation, taxes, those are all included. However, there are some other operational items that are mentioned in this toolkit that need to be considered when contracting with a PCP and an RDN. And to be honest, these are things that you can always refer to, because any employment or business contract will and should talk about each of these considerations. So professional qualifications, office space billing, compensation, work schedule, marketing of nutrition services, RDN responsibilities, a non-compete clause, length of contract, terms of termination, indemnification clause, benefits, and there's plenty of more, but that's a great list to start with. So that is the end of Module 1, Payment Basics. We covered a lot of information in these 3 lectures, and given the scope of this course, I just wanted to provide you general exposure, and I know we got into some detail. So to put your mind at ease, I wanted to talk about the quiz structure real briefly. I have designed the quizzes to test your understanding of major concepts and general overview. So this will be a lot of terminology and definitions and large application. I also will test your ability to reference the course materials and resources and identify resources. So with that in mind, I want to make sure that you don't get caught up in all the details. Again, this information was very detailed, and it is always in flux. We are looking to change the coverage benefits. We're looking to change many of the systems that we use. And so I don't want you currently memorizing it, because by the time you get out to practice, it may have changed slightly. And all these details are different from plan to plan and program to program. So don't memorize the details. I mention caveats, I mention conditions in the lecture because I want you to be aware of them. You may be tested on their presence, but you will not be tested on the specific caveats and conditions. To put you more at ease, I am going to open up the first quiz so that you can repeat it until you pass it. Now, this isn't a ticket for you to do this quiz as a mindless act and go in and just guess your way through it. The whole point is so that you can become familiar with the way in which I write quiz items, and because repetition does help with knowledge. And since what I want you to get out of this class is that in 4 or 5 years from now, when you're doing your own billing, you can go and reference your notes and reference the resources. I want you to know your notes and resources. I want you to know what you have. So if I have you right now go back to it and go back to it and look at it again and again through our quiz, that's fine. As long as you leave this course knowing what resources you have and the basic concepts, you will be ahead of anyone else who has not taken a course like this. If you have any questions, please feel free to email me. You can also message me through Canvas, and I'd be more than happy to hold a Zoom meeting with you if you want to meet face to face.